Moving on to the next session, I'd like to invite our judges, Dr. R.C. Gupta.
Yes. Yes, I'm here.
Good afternoon, Doctor. Dr. Sapta Girish.
Yes, Mr. Raj, I'm here. Very much.
Good afternoon, sir. Dr. Marianne.
Yes, I'm here. I'm here.
Good afternoon, ma'am.
Yeah.
I think Dr. Gagan and Dr. Harik are also there, right?
Blepharophimosis syndrome क्या होता है?
Yes, I'm here.
Our presenters are Dr. Harika.
Wait, एक वो है ऑर्बिट ओकुलोप्लास्टी वाला है मैं इधर बैठता हूँ.
Our presenters are Dr. Harika and Dr. Gagan Dudeja.
Good afternoon.
Good afternoon, ma'am. I'll request the judges to take over and call the first presenter for the presentation.
And Dr. Gagan. Is Dr. Gagan is there?
I'm ready. Give me a minute.
Our first
Yes,
speaker
Dr.
is,
Gagan is there. I think the first speaker is Dr. Harika.
yeah.
First is Dr. Harika.
Harika, okay.
Should I share my screen? Sure.
Yes, please.
So for the presentation, ma'am, it will be 6 minutes and 2 minutes for Q&A.
Okay. I'm starting. Good morning, one and all. So today I'll be presenting on clinical pathological features and management of advanced iron orbital plasmacytoma. I have no financial interest to disclose. Expect the best, plan for the worst, and prepare to be surprised. Orbit being in Pandora's box, I'm sure all of you agree with the above statement. Plasmacytomas constitute 5 to 10% of all plasma cell neoplasms and only 1% of the orbital tumors. Orbital plasmacytoma is an uncommon presentation of multiple myeloma. In more than half of the cases, it is only discovered after the diagnosis of multiple myeloma. We aim to study the clinical, pathological features and management of advanced iron orbital plasmacytoma. This was a retrospective observational and interventional case series in 6 patients from 2013 to 2019. I'm going to discuss 2 cases in detail. This is a 20-year-old male patient presented with a painful, gradually progressive swelling of the right lower eyelid since 40 days. On examination, there was a hyperglobus of 3 mm, temporal fossa fullness with ecchymosis, and the tarsal conjunctiva showed chemosis. The CT scan orbit showed a well-defined heterodense mass centered in the zygoma with orbital and temporal fossa extension with specks of calcification with bony erosion. Coming to our second case, this is a 70-year-old elderly male presented to us with the complaint of swelling in the left upper eyelid since 18 days, which was painless and progressive. On examination, the anterior segment was normal. There was a hypoglobus of 2 millimeters, proptosis of 5 millimeters. The patient had limitation of extraocular movements in all the gazes and except inferiorly, and diplopia in all the cases. The MRI showed well-defined soft tissue mass in superolateral aspect of the left orbit, which was iso-intense and T1 and T2, causing destruction of the adjoining left frontal bone in the roof of left orbit with intracranial extension in the left frontal lobe. The CT scan confirmed the destruction of the roof and the lateral wall of the orbit, causing compression of the superior surface of the left lobe and abetting the superior rectus. These are our other cases presented similarly with proptosis, ptosis, and the swelling of the lower lid, and the CT scan showing orbital mass with destruction of the orbital bones. So the mean age of presentation was 55.5 years. Male to female ratio was 2:1. Most commonly, there was unilateral presentation, and the mean duration of symptoms was 27 days. A multi-level incisional biopsy was done in all of our patients, and light microscopy showed diffusely distributed plasma cells and plasmablasts. These cells were positive for CD138. Kappa light chains were diffusely seen in cases of multiple myeloma. Once we have the diagnosis, systemic evaluation for multiple myeloma is very important to prognosticate the disease. 3 of our patients had multiple myeloma. Coming to the management options, radical radiotherapy has an excellent local disease control since the tumor is radiosensitive. In this particular study, the relapse rates were relatively low with radiotherapy alone when compared with surgery and chemotherapy. There is limited literature with few case reports on systemic chemotherapy in management of these patients. Autologous stem cell transplantation was reserved for many multiple or recurrent lesions. 4 of our patients received external beam radiotherapy. 1 patient got systemic chemotherapy with bone marrow transplant. 1 patient did not follow the treatment advice and was not investigated further. Coming to the treatment response, 4 of our patients did well, with 1 patient showing complete clinical radiological regression, and 3 patients showing regression with clinically inactive, minimal radiological residual stable disease, and 1 patient succumbed to systemic metastasis. At a mean follow-up of 3.4 years, 5 of our patients are doing well with good visual acuity. The revised International Myeloma Working Group has given certain diagnostic criteria in 2003 for monoclonal gammopathies, multiple myelomas, and related disorders. Plasmacytoma can broadly be classified into systemic disease and localized disease. The localized disease can further be classified into solitary plasmacytoma of bone where single bone lesion is seen, solitary extramedullary plasmacytoma where single soft tissue lesion is seen, and multiple solitary plasmacytoma where multiple sites of disease in the bone and soft tissue are seen. The factors responsible for rapid conversion of plasmacytoma to multiple myeloma should be kept in mind and evaluated. To conclude, although plasmacytoma of the orbit is rare, ophthalmologists should be familiar with it. Systemic workup for multiple myeloma is very essential to guide the treatment and to prognosticate the disease. Detailed histopathological evaluation with immunohistochemistry is important, and role of imaging should be focused on early detection of additional or recurrent lesions which influence the clinical management, and aggressive and early initiation of multimodal treatment is warranted. So our study, what is added in the literature? The plasmacytomas should be one of our differentials in a case of bony triradiate lesion irrespective of age group. Our study includes the youngest male reported in literature till date. And typically in bone marrow biopsy, we have seen that patients with less than 10% plasma cells in bone marrow showed good response, less than 50% of plasma cells showed partial response, and more than 80% plasma cells showed poor response. However, further studies on correlation would definitely help in managing and prognosticating such patients. These are my references. Thank you, AIOC, for giving me this wonderful opportunity.
Thank you, doctor. Any questions? Judges, any questions?
Yeah, Dr. Hairika, very good presentation.
Thank you, ma'am.
Yeah, how many of them had solitary extramedullary lesion?
Ma'am, 3 of the patients had solitary extramedullary lesion.
Yeah. How did you treat? Is it complete excision followed by radiation, or?
We have given, we have done incisional biopsy first, ma'am. Then once we have the diagnosis, so we have done the systemic workup for multiple myeloma. And after that, we have recommended EBRT to those patients. And we have been following them 3 monthly for 3 years. And we are planning to follow up annually till then.
Okay.
So in all cases of this type of swellings, you are doing similar biopsy? Or
Yes, sir.
there is some non-invasive investigation before by which you are suspecting something and then going for incision biopsy?
No, sir, because once we have seen the triradiate lesion, so this is one important differential. So we went ahead with multi-level incisional biopsy in all our patients. So once we have the diagnosis of plasmacytoma, then we have done bone marrow biopsy and further investigations for multiple myeloma.
No, since see, this is not very, very common disease.
Yes,
so swelling, any type of swelling or any swelling of mass is not necessarily going to come out as a plasmacytoma. So doing injudiciously the incisional biopsy, because you see in many cases we should have some non-invasive investigations or some markers in which you suggest or you are nearing to the diagnosis, then it is advisable for going for this instant biopsy, because many times you need to have external biopsies or some other modalities of treatment. So how do you suspect actually?
Yes, sir. So one is we have got differentials, especially in if the younger.
Sorry to interrupt, ma'am. The time is up for Q&A.
Should I continue?
Can we, judges, can we move on to the next speaker?
Yeah, please.
Calling on to the next speaker, Dr. Gagan Dudeja. Yes, sir, please start.
Good morning, everyone, respected judges and colleagues. I am here to present our work on epithelial to mesenchymal transition in retinoblastoma. It's a new intervention target. I have no financial disclosures. All of us see and treat retinoblastoma cases, and we know that it is one of the few diseases in ophthalmology where life is at risk. Patients, if not treated, can die. Unfortunately, India also has the largest number of new retinoblastoma cases in the world. And if we see the current treatment modalities, you get a good outcome in the group A, B, C disease, which is what West sees. Whereas for us, we see more group D and E's, where the prognosis or the salvage is poor. So this was the thing in mind, the huge number of cases and the burden which we have. We thought, okay, let me do something if I can change and get some research done in this. Because you can't expect West to be doing research on our problem. They don't have these kind of cases. So one of the things which is in literature is there is a role of EMP in other kinds of cancer, like breast cancer, lung cancer. We thought, okay, let us check whether EMP plays a role in metastasis, advanced diseases in retinoblastoma and drug resistance. So what happens is an epithelial cell is bound to each other. It has got tight bridges. Epithelial cell, once it loses those bridges, becomes a mesenchymal cell. A mesenchymal cell has got a stem cell property. It can move about. So here it shows an EMT, an epithelial to mesenchymal transition, which then causes drug resistance or resistance to even radiotherapy, can also cause metastasis because it is mobile. It can start the cancer, or it can, make cancer more invasive. So these are all cancer progression markers, cancer hallmarks, and EMT plays a role in many other cancers. With this kind of information, we also have epithelial markers known to us on your left, and we have mesenchymal markers known to us on the right. So now the step was, this was not described in retinoblastoma when I started this work. So we thought, okay, let us see whether EMT markers are at play in retinoblastoma. If they are there, can we identify and prove them on an in vitro model and find some signaling mechanism to target them? So we took enucleated eyes and took the tumor from them, and we found these all proteins to be upregulated in gene expression microarray. So this is what you saw before, and we found these other genes to be downregulated. Just focus on this heat map. The dark blues are the upregulated genes, and in an advanced RB, you see lots of blues here. So we find lots of genes more in advanced RB, typically ABCB1, which is also called MDR1 drug resistant gene, and ZEB1. So these two findings were our own. So we found all these genes responsible for EMT and drug resistance here. So we went to the next step and tried to see the expression in live RB cells, that is very RB1 cell line. So here, when we do a microarray, we find, a qPCR, we find NCAD and Vimentin being high, which is again an advanced stage, this blue bars. And then you also find these all blue bars high, which is FN1, SMA, twist and snail, which are metastatic markers. And high BCL, XL, and AKT are associated with better survival and resistance to chemo. The green ones are controlled. So you can see the blue ones are up. So this proves that what we saw there also exists in a cell line. And this is a separate one for ZEB1. This is where we have used a chemo-resistant cell line. And you can see that ZEB1 is raised. This is chemo-resistant retinoblastoma cells to carboplatin and topotecan. So after this, we want to check the protein expression in a Western blot. And here, if we see Vimentin, twist, and N-cadherin are high, these are mesenchymal markers. And E-cathepsin, which is the epithelial marker, is low. And interestingly, you also see phosphobipacatenin, which is raised. This signal is indicative of a Wnt signaling pathway. In Wnt signaling pathway, you get a raised phosphobeta-catenin. All this information then is a small flow chart where EMT is working for a retinoblastoma metastasis. So ZEB1 activates EMT, and then we have the cathepsin, and that leads to tumor invasion, and cathepsins come in play, which lead to blood vessel invasion, and then micrometastasis and metastasis and colonization. The most interesting slide of my presentation is this. We already have drugs which target EMT pathway. They are being used in many other cancers. So once we have discovered this, we have ready-made drugs. One of them may work against retinoblastoma in conjunction with the current medication alone, And, it can help in changing the chemo resistance. It can help in preventing metastasis, or, if an advanced disease, a slide I showed where there is advanced local disease, but no systemic metastasis, these drugs may help prevent that. So this is a crux where, we are very excited that our discovery can have a clinical application. We need not wait for a drug development to happen over years. So in conclusion, we know that EMT is associated with tumor metastasis and drug-resistant other cancers. Our study demonstrates for the first time role of ZEB1 and ABCB1 or MDR1, the resistance gene in EMT and drug-resistant retinoblastoma tumorigenesis. If we suppress EMT, which we showed, it can halt metastatic propensity and also reverse chemo resistance in retinoblastoma. It also provides us with a new therapeutic intervention target, since antifibrotic drugs are already clinically available, which I showed you in the last slide. Currently available drugs hence can be repurposed for blocking the pathway. And very interestingly, there is a role of ZEB1 transcription factor and Wnt signaling pathway in driving EMT. So this ZEB1 transcription factor is a new pathway and a new signaling molecule, which we can do further research on. Thank you for your kind attention. These are the references.
Dr. Gagan, I think this is a very good initiative, and the concept of the treatment which you are suggesting is actually good. Actually, if it gets success and in further experiments, I think it will give a very, very long pathway to the treatment management of retinoblastoma.
Hi, Dr. Gagan. Congrats. Nice presentation.
Thank you. Hi,
nice paper.
Thank you.
Yeah, it does give us more insights into looking at other probable modalities of treatment apart from what is already being done as far as chemotherapy is concerned. And as we know, some of the drugs which actually target the EMT pathway, that is block the EMT pathway, are actually something which is quite easily available nowadays, like the disulfiram, metformin, curcumin extracts. They're actually quite available, and there may be more additives in the ongoing chemotherapy for patients who are having metastatic retinoblastoma. So interesting findings. Quite nice presented.
Thank you.
And Dr. Harika, that was a very nice presentation too. I mean, we ran out of time, but that was a nice one.
Doctor?
I have no other questions. I mean, Dr. Gupta or Dr. Marian, if you have anything?
No, we can, no further questions.
Okay, doctor. Can we move on to the next session?
Yeah, thank you.
Thank
you, and very nice presentation.
It was a wonderful
and Dr. Gagan.
Thank you, doctor.
Thank you.
Thank you so
Thank you,
much.
and all the best to both of you.
Thank you.